and he's going to talk about health policy initiatives to expand living kidney donation. Thanks, Jag.
Does that work? Perfect. Thanks very much. Thanks, everyone. It's a pleasure to be here. I wanted to talk a little bit about, there's a primary initiative we're going to talk about, which is the Transplant First initiative, but we thought we'd just talk a bit about a broader context of what we're trying to do to expand living donation and improve access to living donor transplant in the kidney transplant program. So first, I'd like to acknowledge that we here are working and playing and residing in the land of the Coast Salish, the Musqueam, Tsleil-Waututh, and Squamish nations, and thankful for all the support we get for the work that we do in working with those communities. So I'll start by a bit of a national and provincial outline, just to give a sense of where are we in terms of living donation and transplantation in Canada and in our province. And then highlight some key principles we need to kind of think about when we're trying to improve access to living donor transplantation. And then specifically talk about the Transplant First initiative and talk a bit about the Bridge initiative, which is similar in scope but focused on the Indigenous population. And then end with some challenges and learnings if we have time. So this is the state of living donation in Canada going back 10 years. I don't have 2022 on there, but it's pretty much the same as 2021. So really anyone can see that's a pretty flat line. There's been some growth over time, up and down. 2020 was COVID, that was a down year. But all in all, it's been pretty flat. And that's despite a number of initiatives that we all know have taken place nationally to expand living donation. These are the numbers in BC. Now, for those of you that have been here for a while, you know that living donation has been a real strength of our province, and we've had the highest living donation rates in the country by a large margin. This graph on the left here is from our 2022 annual report for BCT. And you can see that in blue there's Canada, and in the pink it's BC, and we've always been dramatically higher than the rest of the country. The pandemic really hit us hard, and we have not yet fully recovered from that. And so we're running around national averages now, but really I think there's a big issue there. If we look on the right, that's the percentage of preemptive living donor kidney transplants. And despite the dip, we've sustained that in the sense that among those people that get a living donor transplant, about 40% are done preemptively, meaning before the dialysis is initiated in those patients, which is by far the best therapy for any patient with kidney failure. So we're able to keep that going, but the overall numbers have certainly dropped. If we look at the absolute numbers of preemptive transplants over the last 3 years, this is what they look like in the fiscal years, and this is broken down by health authority. And you can see that it's spread out, but there's some variability if you look at Northern Health, for instance, where there's some challenges. Now, coupled on top of that, when we're talking about living donation and access to living donor transplantation, we know that there's additional disparities. This is just one example. There's disparities in terms of sex, there's disparities in terms of income, there's disparities in terms of race. And so this is a study that's done a long time ago, but it shows you that if you look at access to transplantation in South Asians and East Asians, it's about 30% less to undergo a kidney transplant in total. And when you look at living donor transplantation, those numbers blow up. And so you got 70% lower likelihood of a living donor transplant in East Asians and just under 60% in South or Indo-Asians as stated in the study. If you look at Indigenous populations, it's the same picture. The data we have for Indigenous populations, by the way, is really, really poor and very, very crude, which is why all you're seeing here is big proportions. But the bottom line is that we're getting reduced access to transplantation, and particularly living donor transplant in this community as well. So the big question is, well, how do we actually address this? So there's general community awareness about living donation. There's much like we do for deceased donation and say, let's increase awareness. But ultimately, there's something going on from a health services standpoint that we need to address, and that's the attempt that we're trying to do here. So the key principles when doing that is what do we need to actually leverage, and what do we need to ideally have in place to make these things happen? So it really does help if you have an interconnected health system. So what do I mean by that? Well, the spectrum of kidney disease ranges from early chronic kidney disease to dialysis to transplant. And in most places in the world, it's quite fragmented. So the people looking after CKD have nothing to do with the people doing transplant and dialysis, and it's kind of all over the place. Fortunately, in BC, we're in a better position than that, which allows us to actually do some of these initiatives. The second thing you need is to have active, purposeful engagement with all the stakeholders. Now, that ideally should include patients as well and the relevant communities, and that's another key part. Third, your interventions need to then be co-developed with those key stakeholders so they're actually going to be feasible. And then lastly, you have to implement them and evaluate them in a way that you can actually learn from them. So this was an interesting study that was done not by any of us, but it was done about BC. And it was looking at the health system barriers and facilitators. And what they did is they kind of looked at living donor transplant and they said, well, what helps make it happen and what doesn't? And the reason why BC was chosen to look at this is because we excelled in living donation. And so what was working and what wasn't. And if you look at the right, those blue circles there, really that highlights the stuff that's working and what I've just alluded to. A centralized infrastructure, a mandate for timely intervention, an equitable funding model, a commitment to collaboration, and cultivating distributed expenses. And so those are the things that we have in BC that have led to our success, at least in part, in the past. But there's still a number of challenges, which is missed training opportunities, disconnected care processes. There's still issues that we need to address, and that's where we need to focus as we're moving forward. For those of you that may not be aware, this is the organizational structure in our province. You've got the broad provincial organizations under PHSA, predominantly BC Renal and BC Transplant. We have important partners in the Kidney Foundation that helps facilitate living donor expense reimbursement programs and those kinds of things. And then we have our care teams, which is regional kidney care clinics. There's pre-transplant clinic and the transplant center, as well as the transplant programs. And then you have dialysis units spread around the province. And then, of course, at the heart of it, you've got your patients, which are donors and our recipients. This is what it looks like on a map. These are the CKD clinics around the province, the chronic kidney disease clinics. On the right there, you can see them kind of mapped out in terms of the different spots. There's 15 of them. You can see that the ones in the north are alone and kind of, working quite isolated in those environments. While that's regionally distributed, our transplant care is, for good reasons, focused here. Now, this comes up a lot. Why can't we have transplant programs distributed around the province? Wouldn't that solve a lot of our problems? And it's easier said than done, because in order to have a transplant program, it's not just about having the transplant surgeons and the transplant nephrologists and a nurse and a social worker. It's actually about making sure you have all of the consultant support, the ICU support, the dialysis support, the cardiology support, everything we need to facilitate the transplant period and everything that happes thereafter. Transplant ID, as we just heard about, is critical to this stuff. So I think that, it's a bit pie in the sky to say we're going to actually take this transplant model and completely blow it up and say, let's distribute it around the province. So we have to work with what we have and see how we can improve it. I do want to start with in terms of where we are in BC, and this is a nice simple metric that looks at how we're doing in BC overall in terms of access to transplant. So this is national data, and it's simply looking at all the people who are alive with kidney failure, irrespective of whether they're transplanted on dialysis or have chronic kidney disease. I think this excludes CKD. This is looking at dialysis and transplant. And what percentage of those patients in the province are transplant patients, and what percentage are not yet transplant patients? So what we should see is that most patients, or the majority of patients, are transplanted, because that's what we anticipate should be eligible for a transplant. And so if you look at the national average, across the country, about 43% of all kidney failure patients are transplant recipients. If you look at every other province there, BC is the only province where that number is greater than 50%. Everyone else is hovering somewhere between 45% to 25%. So we are doing an exceptional job of giving access to transplant. That number should be 60% or 70%. So if we're thinking about benchmarks of where we want to get to, this is a very simple benchmark for us to think about as to where we want to get to. So active, purposeful engagement of patients and communities. I won't go through this in detail. All I really want to highlight here is that I think as a community, when we're looking at interventions that we're trying to change health services and even health policy, this is something we probably can do a better job in. And we're doing it, and we're starting to do it, but I think we could do more. So most of our interactions with patients is in direct clinical care. We're starting to incorporate patients in some of our decision-making on an organizational structure. But when it comes down to policy making and when it comes down to implementation, for the most part, we're not actively involving patients. And that's something that I think we're starting to get better in, but it's just something to keep in mind that we need to do. Now, in terms of interventions co-developed, I talked about that already. And in terms of implementation and evaluation, I'm just going to give the examples that I wanted to talk about today. So the Transplant First Initiative, and then a bit about the Bridge to Transplant Initiative. So the Transplant First Initiative has been going on for a number of years, and the goal is to implement and sustain an enhanced pre-transplant clinical process, along with the available tools and resources across those regional chronic kidney disease clinics and the regional transplant clinics and the provincial transplant centers. The goal is that every patient who is pre-dialysis, that is a potential kidney transplant candidate, is identified, they're assessed, and then they're supported through the path towards transplantation, because that's the treatment of choice. And that includes help supporting them in identifying a potential living kidney donor. Oops. It's glitching a bit here, sorry. There we go. So this is where it started. So it started in 2015, where BCT got funding to actually start funding pre-transplant activities. So if we think about where that went, BCT didn't used to do that before. So BCT now had the ability to get people in place and fund resources so that all the regional programs that are referring these patients have some funding to actually do some of these activities. In 2018, the Transplant First Initiative was initially launched, and the first phase of it went from 2018 to when the pandemic started. And the real emphasis there was actually on this idea of let's shift the culture in all of our regional clinics to transplant first. So the idea where it's not pathway to dialysis, it's pathway to transplant if you can't get a transplant pathway to dialysis. And so that really involved a lot of education of staff, going through all kinds of things and talking about the education around living donation and how do we support patients in that journey at a very early point. And then in 2020, where we got to was saying, well, we need to implement more standardized workflow. So what came out of that first phase, I should say, is that we got a lot of referrals. Not necessarily the same, not necessarily more living donors, but we did get more referrals. So we were seeing people, but a lot of those people didn't have living donors. And so I think what the messaging we were trying to get out was educate. If they have a living donor, get them seen. And I'm not sure if that education piece wasn't happening, or maybe it wasn't resonating with patients at that level. We're not sure, but the point is that it was a challenge. And then in 2020, we said we need to implement more processes, and that's kind of been the second phase. So this is what we've been working on the last few years. And so this is, if we think about the pre-transplant workflow, I say distinct from RRT. That means that we want to think about transplant not lumped in with dialysis. So a patient who's approaching kidney failure, the discussion shouldn't be, okay, let's talk about what's going to happen next. You got dialysis and you got transplant. Let me tell you about both. Now, for practical reasons, that still happens a lot. There's smaller clinics that don't have the staffing and the ability to separate and have that distinct conversation. But conceptually, it's important to think about it that way. So you say transplant first, make sure you wrap your head around that, but then don't worry, we also have dialysis if need be. And that's kind of the piece here. So key pieces are, first of all, communication is going to be important throughout the entire journey. Identifying and educating patients about transplant, about living donation, that's got to happen throughout because it's dynamic, right? Someone might not be a transplant candidate today, and then they are a month from now when some of their acute issues have resolved. Screening and testing is the next piece, and then triaging and assessment is the next. And then on the donor side, it's communication, identification, workup, and approval. Now, importantly, most of the Transplant First initiative has emphasized on the transplant candidate side of it because that's more complicated. All of the donor piece happens at the transplant center because the donor is going to self-refer, all that's going to happen there. And so that piece has happened more piecemeal, and there's been some efficiencies there, but the focus today is going to be on the transplant candidate workup. So these are the activities that we've kind of looked at. So who should be identified and who should be educated? Those that have a GFR under 25. Now that's pretty early, but it's important because it takes a long time to get people through this process and particularly wrap their head around what they need to do and find a donor. Second was identify if someone's eligible for education, give them the education, talk about living donor outreach, and then if the patient's ready to move forward, you go ahead to screen and test. The screen and test piece is thinking about Is a patient referred? When are we initiating this? How long is that process taking? Have we started a formal living donor outreach plan to support them? What's the referral status? How does that work? And then triage and assessment has to deal with the transplant program doing their part of it. So I wanted to present this actually just in terms of some data. So these are indicators that we developed as part of Transplant First. And this is key because this is kind of high-level indicators to give us a sense of what's going on. And that's supposed to help streamline where we should direct our efforts. So we'll start with the identify and educate component of this. So for the metric, we were actually more conservative. So we said, forget 25, let's look at under 20. If your GFR is under 20 and your age under 80. So a pretty broad metric of patients. We believe that those people should be identified and educated. And so we looked at what the data was in terms of how many potential candidates are recorded in PROMIS. So there's measurement, there's recording spots for this in PROMIS, which is good, so we can track it. And so if we look at the average, about 71% of patients in BC as of March 2024 who had a GFR under 20 and were under the age of 80 had something documented in PROMIS that they either are or are not a candidate for transplant education. So that's a third of the patients missing. Our target was at least 80%. And if you look across the different regions, I've blinded the health authorities here for the purposes of this presentation, but you can see that there's variability across the different health authorities in terms of where we are. Sorry, this is glitching a bit here. There we go. So the takeaway from that is we need to improve some screening. Right? So if we think about that, well, what are the potential barriers there? Well, number one that we've heard, because there's been lots of back and forth with our clinics here, is that there's some confusion about eligibility. Clear-cut patients make sense. Clear-cut contraindications make sense, but there's a growing group of patients where it's not that straightforward. Are they eligible? Are they not eligible? Do they have a donor? Do they not have a donor? So this is a big issue. The second issue is very real, and this, I think, really the pandemic set us back even further on this, is workload. It's not an easy process to screen patients and document it. So the screening might be happening, but it might not get documented in the same way. And so that's something we need to address. And the third piece is something I alluded to earlier, which is this is dynamic. So screening a patient today doesn't mean you don't have to rescreen them at a later time point depending on their health status. So those are some of the key barriers. Some of the potential solutions that we've worked on through this then is to have some clearer guidelines for eligibility. And the second piece is the hardest one to work on, but we are working on it. And again, it's a manpower issue on the transplant center side now, is mechanisms to refer without full screening. So what that means is for those patients who are they eligible, are they not, there has to be a way for you to get a quick opinion from us as to whether they are or are not worth pursuing further at this point. And that happens right now basically through telephone calls from the nephrologist. But that's, again, an issue that could be standardized much more so in terms of this process. The other piece is ongoing education to highlight how critical this is. Early transplantation is a big deal. We're not just saying it. I'm not just saying it as a transplant nephrologist. I am, but if I had to be objective about it, the data speaks volumes. You want our patients to have our best outcomes, we have to be transplanting them as soon as possible. That's kind of the primary. So that has to be a priority. And the reality is you can't have education that's piecemeal. It's got to be ongoing. We've had lots of turnover in staffing during the pandemic and since then. So this is not, hey, we did the education in 2020, we're good, we need to keep doing it. The next piece of this is screen and test. So for this, the metric was we wanted to kind of get a sense of how efficient is our process here. So we looked at all CKD patients that have a living donor either registered or they've said, and this has been documented, that, yeah, I've got a potential living donor on workup. So this is the only fair group to look at this metric in. We're not looking at patients who don't have donors at this point. So this is looking at how much time it takes from the point of referral being initiated to a referral being submitted, because there's a whole bunch of workup that has to happen from initiation to submission. And so our target was 8 weeks, and if you actually look at the average right now, it's about 8 weeks. And some people are a bit longer, some people are a bit shorter across health authorities, but the average looks like we're kind of on point in terms of where we need to be here. Now, if we think about this, the timing is at target, which is great. But there's always a but. And so the but is that we have to, it's the first time we're using these metrics. And so we have to interrogate these metrics a little bit. So we're not really sure when that what the patient status is at referral initiation. So anecdotally, what we hear from some programs is that actually patients have that process has started quite a bit earlier. It's just the computer entry for the referral initiation hasn't happened. So a lot of the tests might have already been ordered. A lot of the stuff might have happened before that referral initiation button was submitted. But so this might not tell us what's happening and what some of those delays are in the true sense of it. So we need to actually standardize what that looks like now and have a better look at what that is. The other thing we need to understand is access to testing. And this is an important issue, I think, because I think if we look at the regional variability, there's no doubt in my mind that one of the factors is the fact that availability and access to echoes, to MIBIs, to consultants, to whatever you need to get done is very different depending on where someone lives in this province. And we haven't articulated that very well to date, and that's a project we're working on right now to kind of at least understand that a bit better. Now, this other part of this is what happens, the referral's been submitted, so now what happens to a patient once they've come to our program? So KCC patients, again, with a living donor registered or there. So you can see things change big time here in terms of our closeness to that, our ideal. So in BC, it's an average of 44 weeks of when the referral is submitted to when a decision is documented. This is how long it takes now for that transplant workup. And there's some variability, but all in all, it's long in every health authority. Now, this is breaking that down into little pieces here. So this is now looking at the time points. So that was just looking at referral submitted, decision documented. But there's a couple important steps. So this looks at referrals submitted to first clinic appointment for assessment by the transplant team. And so you can see our benchmark is 6 weeks. We're generally sitting at around 16 to 18 weeks. I've taken away the overall BC because I think there was a mathematical error in the graphs that we had. It was like 8 weeks. It didn't make sense. So the average kind of, you can see looking at the other bars, is probably around 16 weeks. So that's an issue that's taking so long. So why are we seeing such delays from the point of referral submission to a clinic visit? Why is that taking 4 months? So potential barriers are these. Number one, up until now, there's been a lack of a formal triage role in the transplant program. So you submitted a referral, and there was no single person whose job it is to say, I'm vetting all the referrals, I'm triaging them, clarifying, and getting things moving. That wasn't happening. And there was also inconsistency, therefore, on some of the triaging decisions because you had different people doing it all the time. Also, there was a challenge with often there's incomplete referrals. So testing's out of date, there's missing tests, there's back and forth. So the referral's submitted, but then there's more work that has to be done before the patient can be seen. The third issue was what I mentioned happened after the transplant the first phase of it, where we said refer patients. So we had a bunch of referrals early, and then people actually didn't have living donors. They might have told you they had living donors, but by the time they came down, either that never materialized or the living donor was excluded. And so now you've got somebody who doesn't have the same urgency to be seen. And so that was one of the challenges there. And then there was a lack of clinic spots and patient-related factors in terms of availability, especially for patients who don't live in the Lower Mainland. Potential solutions that have been implemented as part of this is a dedicated triage nurse role at the transplant programs who are working together to now actually formally triage. And I can tell you anecdotally what that's meant. It's meant that at St. Paul's Hospital, 6 months into having this person in this role, we basically caught up on all the referrals we had to catch up on. So it goes to show you how a very simple solution sometimes can get you to a certain point. Now, it's not just the triage role. We've created more clinic spots. We've done all that kind of stuff as well to kind of accommodate that. And there's a sustainability issue there in terms of can everybody continue to maintain that pace and do we have space to do it and all that stuff. But it shows you it can work. We also need a separate and clear process for early referrals, which is something that is not clear yet, and we're working on that. And then, of course, we need to increase pre-transplant staffing on the transplant side to get things moving, which is also happening. The second part of this is, okay, now you've got transplant assessment to actual decision. That piece, we're much closer to where we want to be. And so the real lag was referral submission to assessment. And that's the piece that really we need to focus in on. Now, either way, if we look at the time to candidacy decision overall, we're for that piece from there, we are close, but if you look back at that, there's still some regional variability, right? Let's see if I can go back here. There's still some regional variability there that's quite significant. And so what are some of the potential barriers there? Well, I referred to this earlier, but I think some of the variability to get testing done, because a lot of testing we do after we see the patient, that could be a major factor. Travel for multiple tests is an issue, particularly for people in rural and remote communities. And we might be seeing a different case mix of patients from both a medical and psychosocial standpoint in different parts of the province. And so these are all important factors that we need to understand. So we need to solve this by having further evaluation of access to testing. So I alluded to this earlier. We've got a project right now with a student and a resident that we're actually looking at access to testing in each health authority. So it's a pretty simple study. We're looking at patients, we're looking at what their availability is for the next available, median wait times, distance to testing facilities, what does that actually look like, and compare that by health authority and see if that marries with some of these findings, and that'll help us understand that piece a bit more. The second thing is then once we understand that, we need to actually look at the different regions and say, beyond testing, what are the other issues and how do we actually support those? And are there specific patient groups in certain health authorities? And this is where the Bridge project comes in. If you look at Indigenous communities in rural and remote communities, more heavily concentrated in the interior and the island in the north, what are we doing for those patients? And is that part of the issue here? And do we need to offer additional supports for those patients? So the takeaway really is, we need more screening. We need to capture our potential candidates a bit better. We need to standardize those referral points. We need more efficiency in terms of triage and then working up patients. So these are some of the things we highlighted. I won't go through all of them, but I'll highlight the kidney transplant readiness report and the kidney transplant tracking sheet. And this is part of helping the pre-transplant process be more efficient. And so this is in Promise now. This is a readiness report that tells you where your patient's at, where have they been seen, where their status is as part of their workup. And that helps you communicate with the patient and understand where things are. This is also the tracking sheet that helps you track the patient also moving through the pre-transplant process. And this also tracks the different tests that are required, when they were done, how far along you are. So this is all new information from Transplant First that should hopefully help streamline some of this. And then I alluded to this throughout the talk, but lots of new funding has come through. And this speaks to the strength of having a kind of provincial program that has the ability to kind of streamline funding quickly and follow the patient. And so 11 new positions from BCT, 5 positions from BC Renal, to fund across the transplant programs and across the pre-transplant clinics to actually do the triaging, to follow up. Because as much as we want to automate this, the reality is it takes people, and it takes people to be on it to make sure stuff gets done. And so that's what's being invested in, which is great. And then we've got a formal evaluation program in terms of where we're going to go. I'm just thinking I'm probably out of time here, so I'm not going to talk about the Bridge program too much, but I did want to just give you a sense of what we have coming up in terms of expanding living donation. So we've leveraged Transplant First because it's worked to use the existing strengths we have in the health system. We already have standardized clinic models across the province, and we can use that to do things. So there's a lot we can do to move things forward in terms of this. And so addressing disparities is a big one. We need to have mechanisms to bring in new potential donors, because we need to go back to this, doing initiatives, and we've got some interesting programs that we're developing that'll hopefully do that. And then we need to streamline the evaluation for more complex patients. I will just show you one slide on Transplant First, on the Bridge program, pardon me, just because I think it's actually relevant to what we're talking about here, just to end. Just forward through here. So this is the Bridge program. So essentially what it was, 5-year project, CIHR funded. We're just starting to implement it now. There's been a lot of development. We're working with Indigenous patients closely, with Indigenous elders, with communities, with FNHA, with Indigenous Health and PHSA, kind of all the partners we needed to say, what are the barriers? How are we going to move forward? In a nutshell, the barriers are our educational materials are no good, our processes are confusing, and we're not culturally safe enough. And patients are coming into our transplant programs and into our clinics with a history of having to endure systemic racism in the healthcare system. And we're not overtly addressing that. And so that's what we need to do. And that's really what the goal here is. So the piece I want to talk just very quickly about is the Indigenous Patient Navigator piece, which is important to help do this. And this is what we're rolling in right now. So I'm just going to cut to the chase on what we're going to do differently. And this is starting right now, being piloted at St. Paul's with Interior Health and Providence. And then over the next 6 months, it's going to be expanded to all the other health authorities. But essentially, we've got Transplant Indigenous Patient Navigator based at the transplant program. And their job is to work with patients to help them work through the process faster. But in order to do that, we need to make sure we see patients early, because our navigator can't do anything if we don't know the patient exists. And so we are piloting a mandated early referral. What that means is that for all Indigenous patients in the province, there's going to be a pre-referral consult that's mandated with the transplant team. That consult's not intensive. It's a chart review. It's a one-pager. It's highlighting us to say, hey, we've got this patient who self-identifies as Indigenous. We will do a formal review of that. We will say, yes, we think this person is potentially a candidate, or they're not a candidate, and you can rule them out. Our navigator then, if someone is a candidate, is available to support that patient from the get-go, at referral initiation, not at referral submission, so that we can work with your teams and with our teams to get this person worked up quickly. And we're going to see people who are Indigenous irrespective of living donor potential preemptively. That's the goal. So everybody's going to be seen early, but what we're going to be doing with them is a bit different. Might be education and support in some patients. It might be a full workup, depending on what's most feasible for that patient to get done. The goal really is to increase transparency and navigation support. And so really, I think this is another way in which we've been able to kind of leverage the patient voice in this a little bit. And I think this will actually have a pretty important trickle-down effect on the whole system. So if we can take, specifically for health authorities where you have large Indigenous communities, this is going to potentially be very different, because we'll be seeing these patients earlier, we're getting them through the process faster. And we've got a lot of funding through the grant and from BCT to actually get this done. So we've got additional staffing, we've got formal roles in place to do this, we have lots of resources to do this. And then there's a whole process that we'll get to. So what we hope that's going to happen is we're going to have transplant and fair referral process, because that early mandated review that we're going to do is actually going to get at some of the feelings some patients have to say, hey, I'm not getting referred because I'm Indigenous. And so we'll be able to look at that now and say, well, is that happening? Is that not happening? But at least there's some transparency in the process now. It's going to be a faster workup. Hopefully it'll be more culturally safe, because there's a whole education component there as well. And hopefully that's going to lead to more donation and transplantation. I'll end there and open it up to questions.
Thanks, Jag. I want to thank everybody who put in their questions in the Slido. I think we would just maybe able to do one or two, just interest in time. And Jag, one of the interests is around why the numbers are so low in East Asian and South Asian populations as far as being living donors specifically.
Short answer is we don't know. We've done a lot of work to try to understand what the issues are, and there are some. So there's one big component, which is simply lack of awareness around it. And I think that speaks to some of the findings we've had with the Indigenous populations in terms of our ability as healthcare teams to deliver that education more broadly to certain communities. And then the other piece is there are some cultural factors relating to family dynamics. What does it look like in terms of the impact of donation? You know, religion doesn't seem to be a big issue. There's not a real unwillingness to donate. It's actually typically people just don't want to ask. So I think it again requires a more focused effort on our part to try to get that trust with people to say you can ask, and just because you ask somebody doesn't mean that they're going to be forced to donate in any mechanism.
There are a number of sort of questions, you know, of urban versus rural, but I think sort of summing up, there was one question along the lines of having potentially some the transplant nephrologists go out to communities for clinics, sort of like the first contact clinics.
Yeah, and that's something we've been looking at. It does boil down to feasibility and manpower ultimately. So I think that model's been shown to be successful in lots of other areas. But the issue is manpower at this point. I mean, in the interim, what we are doing is leveraging virtual care. And so, you know, not every patient, especially when we're seeing patients early, needs to be seen in person necessarily. But the way we deliver virtual care needs to be looked at a bit. You have to make sure people have access to it. So it'll probably be a model through which people can come to their clinic and have a visit through there, so that for people who don't have access perhaps to the tools at home.
Excellent. Thank you so much, Jag, for sharing in, and really look forward to hearing more about the future. Okay.